by Pulukool Sandhya on the advances in management of Sjogren syndrome. Sjogren syndrome is a challenging disease to treat, where the management strategies are evolving, and the new pathogenesis mechanisms are leading to newer treatments under development. And Sandhya has trained her in MBBS from Calicut Medical College, my own alma mater, and then she did her MD in JIPMER, and then subsequently trained in rheumatology at Christian Medical College, Vellore, where she worked as a faculty for several years and is now practicing in Delhi. I would like to invite Sandhya for her talk on the management of Sjogren syndrome.
Thank you, sir, for your kind introduction. And I would also like to thank IRA for giving me this opportunity. So this would be the overview of my talk. First, we will talk about evaluation at the pre-treatment stage. Secondly, I would like to talk about management with regards to Sikka, fatigue, and extragranular disease. I would be talking about specifically about granular, renal, CNS, and complete heart block. And finally, why do trials fail and what does the future hold for us? Now, first, let me start by saying that Sjogren syndrome we know is a complex heterogeneous disease. And the disease subsets, at least which we can identify clinically, we have a glandular only subset, we have a periepithelial subset, and an antibody and immune complex mediated disease. Now, the glandular is exemplified by Sikka, pain, and fatigue. This is the triple complex of glandular subset. Periepithelial classical example is tubulointerstitial nephritis, and antibody and immune complex mediated, the classical example being glomerulonephritis, skin vasculitis, and multineuritis. Understanding the pathology helps us to decide treatment, and molecular pathology in these subsets vary. For instance, in glandular, you have mild glandular infiltrates consisting of T cell, germinal centers are absent, Th17 interferon BAFF are reduced, and antibodies are generally negative or present in low titers. Now, fatigue is very important and interesting. Fatigue has been connected to decreased inflammatory cytokines. So the relation is inversely connected to inflammatory cytokines. And a recent review shows that, recent papers show that there is a connection with proteins in the brain and a neural pathway is implicated. The antibody mediated we know is characterized by severe glandular B cell infiltrates, presence of germinal center-like structures, Th17 interferon and increased BAFF, and high serological positivity. And periepithelial falls somewhere in between. So this understanding, how does it impact management? So those with glandular symptoms alone, they get symptomatic treatment. On the other hand, antibody-mediated immune complex diseases, they are treated almost always with immunosuppression, and the periepithelial in-between group, mild disease you can treat symptomatically, and those with increased disease severity you treat with immunosuppression. Now with that introduction, now let us move on to, so first we know the pathology, now we should know how to measure. Dr. Kavita has already mentioned the two scoring. So Sikka, fatigue and pain. This can be measured by ESSPRI, which is a patient-reported index. So there are scores for Sikka, pain, and fatigue. Out of 10 are average. Total score is out of 10. More than 5 is an unsatisfactory symptom stage. And to say the clinically important difference is defined as a score of more than 1 or 15% improvement. And then you have the ESSDI, which is for capturing the extragranular manifestations. There are 10 clinical domains and 2 lab-based domains, which is hematological and biological. Biological domain consists of C3, C4, and immunoglobulin. Constitutional, lymphadenopathy, glandular, articular, cutaneous, pulmonary, renal, muscular, CNS, and PNS. These are the clinical domains. Now, the score varies from 0 to 123, and you can see that these are weighted scores. And the higher score, yes, defines a disease, higher disease activity. Overall, a score of less than 5 is low ESSDI, 5 to 13 is moderate, and more than 13 is a high score. A therapeutic response is defined as a decrease in 3 or more. Now, why we should know all these things about ESSDI is that the latest EULAR recommendation suggests that treatment of systemic disease should be tailored to organ-specific severity using the ESSDI definitions. At the same time, there are some other concerns. There are organ involvements which is not captured by ESSDI. For example, pulmonary arterial hypertension, which is the next topic, autoimmune hepatitis and liver involvement, protein losing enteropathy, these are not actually captured by ESSDI. So now, what are the goals of therapy now that we have measured? A multidisciplinary approach is recommended. So the first goal is to ameliorate the symptoms of Sikka fatigue pain, prevent complications of mucosal dryness, detect and manage systemic manifestations and lymphoproliferative disease. I would not be talking about lymphoproliferative disease in this talk because lymphoproliferative disease is managed by the hemato-oncologist in our setting. Now, coming to the recommendations and guidelines, there are numerous recommendations and guidelines. But for this talk, I have mainly followed EULAR recommendations 2020, that is the latest, and the BSR guidelines 2017. And so we should know where the evidence for EULAR recommendations comes from. So if you look at the evidence, there are 9 RCTs and only 3 consist of 120 to 130 patients. Compare this with the number of RCTs we have in lupus, which is a disease less common than Sjogren's, and compare it with the number of RCTs we have in RA, which is just a little more than Sjogren's. So I think the ratio should be something like 1:4:8. 1 for Sjogren's, 4 for lupus, and 8 for rheumatoid arthritis. There are 18 prospective studies that have happened so far. It includes only 10 to 50. And there are 5 case control studies. And no drug has been approved for use in Sjogren's syndrome so far. Now, talking about the Sikka features, multidisciplinary approach, close collaboration with ophthalmologist and dentist is required. Baseline evaluation of gland function is recommended, and oral can be measured by unstimulated whole salivary flow rate, and ocular, though rheumatologists do Shermer's in OPD. What is recommended is at baseline, the tear breakup time should be done. The corneal and conjunctival scoring, preferably by OSS, must be done. And these tests are to be performed in this order, otherwise the tests interfere with each other. Now, self-care is an important part, so patient education is very much essential. So what environmental modification as and where it is possible should be done. Tobacco should be avoided. Excellent oral care should be practiced. And specifically, what we are concerned in Sjogren's is the high caries. So that can be prevented by using high fluoride toothpaste. And in case of caries, to heal it, we need to use neutral pH sodium fluoride gel. And for eye care, yes, decrease screen time. And in addition, you have modified spectacles, modified fluid chamber spectacles that is shown on the right. So you can see that by the spectacle is fully covered, and by the side you have a humidity provider tank which can be filled with water 2 to 3 times a day. Minimize the use of drugs that can exacerbate Sikka. And let me say, there is no evidence for use of HCQ, rituximab, glucocorticoid, or immunosuppressive agent in all the trials or the all the retrospective data. There is some evidence for use of oral omega-3 fatty acid based on previous RCT, though the recent large RCT that is called DREAMS that was published in NEJM is a failure. Now, talking about ocular, so this is the flow chart. What you see on the left is recommended by EULAR 2020. And what they say is to define the severity based on OSS and OSDI. So those with non-severe keratoconjunctivitis Sikka and severe keratoconjunctivitis Sikka, the baseline treatment is artificial tears, because we must remember that Sjogren's syndrome is an aqueous deficiency dry eye. So artificial tear is the most important part of treatment, and it is important to use the preservative-free artificial tear, because the preservative that is used in artificial tear is toxic to the epithelium. And these artificial tears, the main constituents are methyl cellulose and hyaluronate. Hyaluronate is preferred in those with severe dry eyes. Following that, those with severe keratoconjunctivitis Sikka have a lot of inflammation. So topical glucocorticoids followed by topical cyclosporin. These are the step-up therapy. Then serum eye drops, and rescue therapies, oral muscarinic agonist and plug insertion. There are other therapies that is recommended in BSR guidelines, that is use of scleral contact lens, corneal grafting, and amniotic membrane overlay. Now there is a move towards understanding the dry eye and treating it based on the tear film. So if you look at this picture shows the tear film. The topmost yellow layer is the lipid layer. And then you have the aqueous or mucus layer, and then you have the epithelium that is in brown. Now the lipid layer is very important, because now it is being recognized that meibomian gland dysfunction is also commonly seen in Sjogren's syndrome, and it contributes to causing fast. If you don't have the lipid layer, your tears evaporate. So that is also now seen exceedingly commonly in Sjogren syndrome. So patients should be evaluated for meibomian gland dysfunction by an ophthalmologist. Tear but less than 10 seconds is an indication of meibomian gland dysfunction. Warm compressors, lid hygiene, use of antibiotics like doxycycline and topical azithromycin when the inflamed meibomian gland becomes infected is required. Now, like I already said, aqueous layer is what is affected in Sjogren syndrome. Aqueous layer has two constituents, the aqueous component and the secretory mucin. Artificial is the most important, but we should know what is new. So there is a secretagogue. It is called dicofosol sodium. And this is a secretagogue which can increase both aqueous and secretory mucin. Now it is being widely used in Asia, including and mostly in Japan and Korea. Now, for the secretory mucin, in addition to dicofosol, as we go down, we have more and more drugs. So in the secretory mucin, in addition to dicofosol, which I said is increases the mucin, you have ribamipide. So ribamipide increases mucin, and it can also heal the inflammation. So in addition to increasing secretory mucin, it is also having an anti-inflammatory effect. So this can be used. If you see the last layer of the slide, the ocular surface inflammation, you have cyclosporin, you have steroids, you have ribamipide, and the newest drug which is approved worldwide in 2016 is lifitegrast. It is still not yet available in India. Now, lifitegrast is an integrin antagonist, and the advantage is that it does not have the adverse effect of corticosteroid, and as compared to cyclosporin, relatively fast action within 2 weeks is seen. Now, as far as oral treatment is required, so oral treatment, the baseline sign that needs to be fulfilled is unstimulated whole salivary flow less than 0.1 ml per minute. Now, it can be further classified as mild, moderate, and severe based on stimulated whole salivary flow, which I do not think is routinely practiced in OPD. Now, basically what we need to know is you have mild, moderate, and severe dysfunction. Those who have severe dysfunction should get salivary substitutes. Those who have mild and moderate, you can try non-pharmacological stimulation with sugar-free candies and chewing gum containing xylitol. And if this fails, move on to pharmacological stimulation with pilocarpine and cevimeline. And in case it fails, you have mucolytic agents and electrostimulation. And treating candidiasis is an important part of oral Sikka. White plaques require topical treatment. Angular cheilitis also require only topical treatment, but erythematous candidiasis can be difficult to treat and requires oral fluconazole. Now, the other interesting thing I mentioned was neurostimulator, which is an upcoming therapy. So this is a device that can be you can insert it into your nose, and this stimulates the anterior ethmoidal nerve, and it increases tear production. RCT has been done in dry eyes, and separately RCT done in Sjogren syndrome has been found to be successful, and this was presented in a conference abstract from Australia. And the oral stimulator has been there since 2011. RCT in xerostomia was success, and this included a subset of patients with Sjogren's. However, not much has been heard about it after that. This works by stimulating the lingual nerve. Now, next, that is all about Sikka. We will move on to fatigue and pain. So fatigue and non-inflammatory pain is a very distressing symptom for our patient. It is very important to evaluate for concomitant disease. For example, patients with RT and osteomalacia can come with widespread pain. That should not be missed, and we should not be treating those patients for just fibromyalgia. Patients with small fiber neuropathy may have unbearable widespread pain. So do patients with lymphoma can also manifest like that. So we need to thoroughly evaluate the patient clinically. Other diseases like degenerative joint disease, thyroid disorders, calcium and vitamin D deficiency, depression, fibromyalgia, all can manifest as fatigue and pain. Hence, antidepressants and anticonvulsants should be considered in selected patients. But the most important measure is not any of these. It is aerobic exercise, which has been proven to have value in a controlled intervention trial and very recently in an RCT. So what I understand is that if you do an exercise which targets 60 to 80% of your maximum heart rate, there is going to be increase in aerobic capacity, and that can decrease fatigue. And this is a wonderful thing that we should advise all our patients to do. Now, next, we come to treatment of extraglandular manifestations, and all our ideas are borrowed from SLERA. Whether it is the trials, whether it's the treatment, whether it's pathogenesis, we borrow ideas. So if you look at it, at the crux of it, you have to look at the ESSI score. You look at the individual organ score, you look at the overall score, and then Those who have life-threatening disease, see the right, you give pulse glucocorticoids, cyclophosphamide, and plasma exchange. Now, those who have specific organ involvement like lymphoma, vasculitis, ITP, and cryoglobulinemia, this is one subset. In fact, in the whole slide, that is the subset which has got highest evidence. All the others, the grade of evidence is 4. That is, grade of evidence 4 means from case reports and case series, and 5 is expert recommendation. So all the others come in that category. So if you have ESS greater than 5 and not this organ involvement, which I mentioned for rituximab, the treatment is glucocorticoid with immunosuppression and modulation. So there are different drugs that is recommended. For example, HCQ is recommended in case of skin joint fatigue, methotrexate, leflunomide, azathioprine, cyclosporin for joints, MMF, azathioprine, cyclosporin for renal, lung, hematological. IVIG has a role in case of severe axonal neuropathy and severe small fiber neuropathy. All the other minor manifestations, we should try for symptomatic treatment, and in case they do not improve, on a case-to-case basis, we can decide on increasing the therapy. Now, I would like to share this data from CMC Vellore, and this is out of our 332 patients. Follow-up data was available for 229 patients. So the most common manifestation, of course, were musculoskeletal. So we have used HCQ in combination with methotrexate, in combination with omega fatty acid, and both together. So this is the major part of the treatment that was given. For systemic manifestation, our go-to drug is mycophenolate, and we have seen a good response. So we had around 40 patients each with lung involvement, renal involvement, and neurological involvement, and we found good response with mycophenolate. And steroids, low dose steroids during the course of therapy was used in 78, and high dose steroid was used in 50. Now, if you look at the outcome, at that point of time, this is the data from 2004 to 2011, 7-year data. So at that point of time, we did not have any of the scoring systems. So we were just looking at whether the patient has improved partial outcome or if the patient had become asymptomatic. So what we could find is that it is easier to treat systemic manifestation and joint manifestation than Sikka symptoms, because 89% of systemic manifestation and 81% of joint manifestation had become asymptomatic. Now, next, I would like to briefly talk about HCQ, rituximab, and about steroids. So HCQ, what I understand is rheumatologists are not willing to give up on their favorite drug, even though overall body of evidence was rated as very low. This is because rheumatologists have vast experience with HCQ, and there is a favorable safety profile. And HCQ has strong biological basis. It reduced the type 1 interferon score and interferon stimulated gene expression in the JACOR trial, where the clinical outcome was not seen. Therapeutic trial of HCQ is advised in skin and joint disease specifically, and fatigue in select situations. Now, no control study has specifically evaluated glucocorticoids for use in systemic disease, so it should be used for minimum dose and duration. Synthetic immunosuppressive agents can be used for their juicy sparing effect. There is no strong evidence for any specific immunosuppressive agent, so choice of any of these drugs, including biological, need to be decided on a case-to-case basis. Now, coming to rituximab in extraglandular manifestations, tears and tractus, these are the two large RCTs of rituximab in Sjogren's, and the outcome in these two trials were based on the patient-reported outcome of fatigue and the VAS scores. So, in these two trials, the ESSDI was included as a secondary measure. In tears, there was no change in ESSDI. In tractus, a decrease in log transformed ESSDI was seen. However, the bulk of evidence for use in rituximab comes from prospective, case control, retrospective, and smaller RCTs, which showed that use of rituximab resulted in response in global, organ-specific ESSDI reduction, prednisolone. At least one of these things were found to improve. And rituximab is perhaps the only drug which has shown to cause recovery of salivary gland parenchyma in histopathology, and overall there is a strong biological basis because Sjogren's is a B-cell disease. Now, in the EULAR 2020 recommendations paper, they have given flowcharts. So I thought I will just touch upon few, and for the detail, you can look at the paper. So for example, in glandular manifestations, what they have recommended is for acute, rule out infection, give an antibiotic trial, treat symptomatically. If the patient doesn't improve, consider glucocorticoids 0.3 milligram per kilogram. In case there is no response, or in case of chronic glandular swelling, we need to rule out lymphoma and other causes. Rescue therapy by rituximab or belimumab has been recommended. In chronic therapy, this is the BSR guidelines. They say that patients have improvement with gland massage in chronic and inflamed gland, and ultrasound should always be done in patients to look for any obstructive features. So if there is chronic obstructive silenitis, there is improvement with interventional silendoscopy and lavage. Now, talking about renal involvement, and one of the most, I think this is one manifestation which would be seen by all rheumatologists working in Sjogren's. So, renal involvement consisting of tubular involvement and rarely glomerulonephritis. So, if we encounter glomerulonephritis, we should rule out primary vasculitis and SLE. Now, the subsequent treatment of tubular and glomerulonephritis is dependent on ESSDI. So then we should know how the ESSDI is scored as mild, moderate, and severe. So mild ESSDI means there is no renal failure, could be RTA or could be glomerulonephritis. So in glomerulonephritis, there should be no hematuria and proteinuria should be up to 1 gram per day. So this is mild ESSDI. It has a score of 5 and they can be treated symptomatically. Now let us look at the other end. That is a high ESSDI group. This is patients with glomerulonephritis. There is no RTA here. Glomerulonephritis having one of the following, that is GFR less than 60 ml per minute, or hematuria, or proteinuria more than 1.5 gram per day, and or biopsy evidence of proliferative glomerulonephritis or cryoglobulinemia. And moderate ESSDI, which has a score of 10, comes in between. The glomerulonephritis comes in between and includes RTA with renal failure. So those who have moderate ESSDI, they should be treated with glucocorticoids, 0.5 milligram per kilogram, and you can use, when they write here second line, what they have said is that whether it is used sequentially or upfront in combination depends on the treating rheumatologist. In case there is no response, or in case of high ESSDI, the treatment is a higher dose of glucocorticoids. Rituximab is recommended in cryovasculitis, or you can also use cyclophosphamide, and in life-threatening cryovasculitis, plasmapheresis is recommended. Now, I would just like to show the RTA-CMC value data. So this is 25 patients of median age 32 years. And this is the other extragranular manifestation seen in those patients who have come with RTA. 4 had vasculitis, MGUS was seen in 3, autoimmune hepatitis and autoimmune hemolytic anemia in 1 each. We did biopsy for 6 patients. 3 had chronic interstitial nephritis, 2 had mesangioglomerulonephritis, and arteriolnephrosclerosis was seen in 1. Treatment was with HCQ in 22, glucocorticoids in 8, azathioprine, methotrexate, mycophenolate 2 each, and cyclophosphamide. So the dose of the other drugs was dictated either by the biopsy finding or the other other component of extragranular manifestation that was present. At follow-up, 2 patients developed CKD and 2 patients had lymphoma. So the point I want to emphasize here is the RTA group is the constitutes the youngest patients with Sjogren's syndrome. All of these patients are antibody positive, and because they are because their disease onset is earlier, and because they have high titer antibody positive, these are the patients at highest risk of complications, including lymphoma. And when we analyze the data of RTA versus no RTA, even if we did not include the renal score, we found that the RTA group had higher ESSDI score. Now, about rituximab in RTA, subsequently we tried using rituximab in patients with RTA. What we found is that you can see this is the ESSDI score at baseline with the split that is mentioned. What we found is that the patients, we could taper the steroids very fast, especially it is very important in RTA where patients have osteomalacia, patients have hypokalemia, and we would like to reduce the dose of steroids very fast. So what we found is that it helps us in managing the organ extragranular manifestation overall, decreasing the steroid, but at 1 year follow-up, there was no reduction in alkali or potassium, which is the same finding which is reported in an RCT where there were 2 patients of RTA included in this particular trial. No reduction in alkali dose was seen. But what just blew my mind is this case report, and there is only one single case report, but I do not think anybody would have tried rituximab persistently for 4 years. When this group did that, what they found is that the renal functions normalized from 46, EGFR was 46, it went up to 71, and the distal RTA improved so much that they could discontinue the oral potassium citrate supplementation. And after the surgical calculi was removed, this was intractable renal struvite calculi, there was no further recurrence of calculi. So this is something to think about, because there are no randomized trials available specifically looking into RTA. Next, talking about the neurological involvement. So multiple sclerosis. So this recommendation is important. So if you have patients with multiple sclerosis, what they have suggested is that they should be treated like multiple sclerosis and use those therapies for multiple sclerosis. Those who have lymphocytic meningitis, treat symptomatically. If there is encephalitis or if there is no response, step up to glucocorticoids high dose. CNS vasculitis and NMOSD should be treated with glucocorticoids and cyclophosphamide, rituximab as rescue therapy, and plasmapheresis if there is cryovasculitis. And because eculizumab has the phase 3 trial has been a success, so there is a recommendation to use eculizumab in echoporin 4 positive NMOSD patients. Then autonomic neuropathy is a very distressing symptom to treat, and the evidence is mainly from very small retrospective case studies. So they have found use of IVIG and rituximab had some response in these patients. Now, I would like to briefly share this experience of treating CNS involvement with meningoencephalitis at Stephens. There were 4 patients out of 253 patients with meningoencephalitis was detected to have Sjogren's. So there were people who had very bad, very low GCS scale, who had to be intubated. Example, the patient number 1 here had dramatic recovery with high dose steroids. But after that, even without a second line agent, this was the patient's parents' interest not to treat with any other drug till there is any relapse of symptoms. So that was a very important learning point, that these patients will do well on low dose steroids, which was tapered and stopped in 6 months, and the patient is now on HCQ, and 1 year has passed and he has not had any other symptoms. The other 3 patients required other drugs in combination, but all of them did well just with low dose of dexamethasone. So the learning point here is most of the patients with meningoencephalitis, my neurologist colleague told me, all these patients would have been treated as TB if we had not considered the diagnosis of Sjogren's, and none of these patients had Sikka symptoms. Now, I would just like to talk about this PATCH trial that has been published in 2020. This is a very important trial. What they have shown is that against the historical rate of recurrence of complete heart block of 18%. So if you have a previous baby with complete heart CHB, the chance of recurrence is 18%. So the mothers who were enrolled in this trial took hydroxychloroquine 400 milligram daily, and they found that against the historical rate of recurrence, the recurrence rate in this trial was 7.4%, a decrease of more than 50%, which is a very good news as far as HCQ is concerned. And finally, talking about CHB management in this, this is from the EULAR guidelines. What they have mentioned is that there is a slight change in guidelines. The recommendation for giving fluorinated corticosteroids in first degree is very weak. Fluorinated glucocorticoids are indicated in incomplete secondary degree heart block and complete third degree heart block pending confirmation. In complete third degree heart block, once it is confirmed that it is complete, there is no point in continuing steroids. The indication for steroids and IVIG in complete third degree heart block is if the patient has if the fetus has endocardial fibroelastosis, hydrops, or poor function. And the second line therapy for these patients is to consider plasmapheresis. Now, finally, I think we should think about why clinical trials in Sjogren's syndrome are dry. There are many editorials written on this, and these are the causes that have been listed: clinically heterogeneous group, chronic disease, faulty design, glandular dysfunction, whether the outcome measures are capturing what it ought to capture, whether we should have patient-reported scales, whether we should have composite outcomes like in SLE, and unfortunately, we don't have a reliable, there is no equivalent for dsDNA in lupus. This chart shows all the most of the randomized control trials done in Sjogren's syndrome, and you can see that other than the top 3, all the others are failure. So there is a record number of failure, and after that, finally, there is some success. And you can also see that the outcome measures have moved from ESS-PRI, fatigue scores, patient-reported outcome scores to ESS-DI, and then combination scores. Now, in this context, it is important to see that what has passed the trials this year is hydroxychloroquine. These are phase 2 trials, hydroxychloroquine and leflunomide, iscalimab, which is an anti-CD40 drug, ianalumab, which acts against the BAFF receptor. So what is one very happy note is the combination of leflunomide and HCQ, which was previously shown in vitro studies to have a combination additive effect. The same group of investigators in an RCT, very appropriately titled Repurpose 1, showed that there is decrease in ESSDAI at 24 weeks. And so with this, I think I can conclude an optimistic note. I would like to conclude. So I think precision medicine, this is again from an editorial. So they say that precision medicine should be the future. This is because when they did clinical phenotyping, practice trial we know is a failure as far as rituximab concerned. Joker trial is a failure as far as HUK is considered. But when they reanalyzed the data based on clinical phenotyping, so they divided patients into different groups. So they found that patients with dryness dominated fatigue, the stimulated salivary flow improved after rituximab, and in Joker trial, improvement could be seen in high symptom burden group. And the other phenotyping that could be done is immune and molecular phenotyping. In this HCQ plus leflunomide combination trial, they found that combination of serum cytokines could predict treatment response to HCQ and leflunomide. So with that, I would like to thank all for patient listening, and I would like to hand it back to sir.
Thank you for an excellent talk, which covered everything and also touched upon the heterogeneity of Sjogren syndrome as a disease, that different patients are different. And there are some interesting questions from the audience here. And Vishad likes to ask about the window of opportunity in Sjogren syndrome. That is are there situations where some of the patients with dryness may be treated at some particular stage? Even we have had experiments when we give some patients with Sjogren syndrome with extra-articular manifestation rituximab, there is dramatic improvement in the dryness symptoms. And this we noticed is occurs in people with good infiltration of the salivary gland on ultrasound, which we know correlates with the histological score. So is there a window of opportunity in treating patients with Sjogren syndrome using more aggressive measures like rituximab?
Yeah, sir, I would like to believe that that window of opportunity exists. So I have looked at those trials where they have given rituximab for the longest period of time. So there is one trial, and it is not an RCT, it is an open interventional trial by Cherubi et al. This is published in 2013. They have given rituximab for the longest duration. What they have done is they have one arm with rituximab, the other arm with DMARDs, and they have chosen patients with some amount of disease activity. And they have shown that they have given rituximab, I think they have given for more than 5 years. So I'm not be correct about the duration, but I think 4 to 5 years they have given rituximab every 6 monthly 2 doses, and they showed that there could be decrease in the salivary gland infiltrates in the patients with rituximab, more in the patient with rituximab, but there was also some decrease in infiltrate in the other DMARD group. And also, like I showed in the case report of RTA, where they have used rituximab, I would never think of doing that. They have given rituximab for 4 years. And if they could reverse calculi and if they could reverse the S doses, so I think there is a lot of hope, and I think it is possible. I think we should be persistent, and personally I feel maybe we should continue giving small doses. We may not require the high dose 1 gram dose. Maybe we should give small dose repeatedly over a longer period of time.
A question from Dr. Danda.
Yeah.